Hey everyone, welcome back to my channel, and if you're new here, I'm Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Dr. Joseph Maccio, and he will talk about his study, Directional Preference of the Extremity. Dr. Maccio is a physical therapist, holds a diploma in the McKenzie method, and has several MDT-related publications. I hope you enjoyed the show. Hi, Dr. Maccio. Welcome to PT Pro Talk. How are you today?
I'm doing great. Thank you so much for having me.
Awesome. So let's start talking a little bit about your background. So just tell us a little bit about your career and how did you get where you are right now?
Sure. So I'm originally from Troy, New York, which is mid-state in New York, and went to physical therapy school in New York City at Downstate Medical Center and graduated in 2008. And the first clinic I worked at was a really good clinic that had a lot of good skilled clinicians. And actually, the first course that I ever took was a Mulligan course. That was my first introductory to continuing education, which I appreciate and like. But the clinic actually, it was interesting. They brought in Stephen Hefner, faculty with MDT, to teach Part A for the whole clinic. So everyone that worked there learned MDT at the same time. At least most of them. Some had a previous background with it. So that was kind of my first formal introduction to MDT, although my father is actually also an MDT diplomat. We're the only father and son diplomats. So I had him kind of in my ear for a while about it, so that he was really my first exposure to what MDT was and how it worked. And it was really interesting because when I was a new clinician coming out of PT school, I didn't feel like my patients were having great success in getting better and doing what I learned in school, and it was frustrating, and I was maybe kind of second guessing the profession that I chose, or it was frustrating, or maybe I just was new and whatever. And I would talk to him on the phone just anecdotally and be like telling him about a patient. And there was one guy, and he was like, "Oh yeah, you just got to go lateral on him." Lateral? What are you talking about? And I did, and this guy got better, and I was like, "You picked that up over a phone call? Are you kidding me?" So I could see how powerful it was and how diagnostic it was, even with a little bit of information. So that really piqued my interest, and then coinciding with taking Part A and exploring MDT made me even more interested in wanting to pursue it. And then, I worked a couple other places, and then wanted to really explore MDT to the highest level. So I moved back to where I was from, Troy, New York, and worked with my father, which I thought would be like a few months to max a few years. And I just saw how quickly and exponentially I was growing professionally and could learn from him. So I ended up staying way longer than that, over 10 years. And it was a great experience, and we got a lot done, including this research and a lot of other really exciting MDT accomplishments. So, and then I got certified pretty quickly, and then became a diplomat in 2013. And through the Texas program in Austin with Chris Chase and Scott Herbawi and Kim Green, who are all excellent. If you ever had a chance to work with them, they're incredible instructors and mentors. And then when I graduated, I was doing a lot of stuff in our clinic, running an MDT student program, running grand rounds for clinicians that work there, and trying to make sure all of our patients were getting the highest level of care that we could offer. And then, kind of to fill like a void, I felt kind of like I was for years going to school and pursuing continuing education, and I was like, what am I supposed to do now? When I was in the diploma program, the gentleman that I lived with and did it with in Austin was very much into research. I was very much just a clinician and didn't care that much about research at the time, and was like, who cares about that? Whatever. Like, and so we meshed well and rubbed off on each other well. We complemented each other's lack of certain things, I suppose. And so when I finished, he started doing research and I started doing research. And I was like, I thought it was kind of crazy at the time. A lot of it, there weren't many. There was maybe a shoulder and a TMJ extremity case report that was published. And I was like, that just seems crazy because it's applicable to everything. I see it effective with everything. It's a bit more confusing, I thought, as an early clinician. And I guess I wanted to fill that void and have a new challenge for myself. So I had the goal to then kind of try to publish every unpublished extremity. So we went out to publish research on the elbow, on the wrist, on the ankle, on the hip. And the study that we'll be talking about is an all-encompassing study on how to predict spinal referral to all of those joints, as well as detect patterns within the peripheral joints and within derangement syndrome, and how to find directional preference more easily with that, which is a continuation of the wrist study that we did. So, yeah.
Awesome.
That's probably enough, right?
That was a good summary of everything. So that's cool that you started having this interest for research, because I feel like most clinicians don't like research very much.
It seems that way, but people are either very good clinicians or very good researchers, and the clinicians aren't good at research, and the researchers aren't good at being good clinicians, so it ends up being poor randomized controlled trials that show poor efficacy. So I was like, I can bridge that gap, hopefully, or try to. So I think I've done so far in what we published.
Awesome. So our goal today is discuss one of your studies, so the directional preference of the extremity.
Yes.
So let's just dive a little bit deeper on that study and tell us how that worked, how it was, what were your goals, and just give us a...
Yeah, so on one of the latter studies, it was a similar study designed to it's the same name. I don't know why. That just seemed to make sense, but it was directional preference of the wrist of preliminary investigation, and that was just 19 consecutive wrist patients, and we tried to predict associations with matching directional preference to derangement syndrome, and just looking at the classification of consecutive patients, and it was the first of its kind, and it was the highest prevalence rate that had ever been published, at a 79% derangement rate in consecutive risk patients, and found 4 really interesting variables that I think make it a lot easier to elicit directional preference. And in that study, we ended up finding a lot of interesting loading strategies and some patterns that just made sense and made it easier to find. So, comparatively, the previous research was showing between like a 20 and 40% prevalence rate in derangement syndrome in the periphery. And, anecdotally, I was like, that's not at all what I see. It's way more similar to spine. It's at a 70 to 80% range. And it was unclear why that was. And within that study, we theorized a couple different reasons. So when that was published, it was kind of like, well, is this applicable to every joint and the rest of the periphery? So that kind of led to this study, because it was really interesting. And in going through that study, I started to see different patterns and recognize different patterns and think differently about my history in the peripheral joint. And anecdotally, it made sense, and I was seeing it. I was seeing those trends and variables elicit directional preference. So I was like, I think it is. Let's try to do a study on everything. So yeah, it was just a continuation of that to try to get more patients and see if it was applicable to periphery. And also, what we didn't do in the wrist study was try to predict if there was spine referral. because I've also see a high prevalence of spine referral to isolated peripheral pain, people that have specific pathoanatomical, lateral epicondylalgia that gets referred from the neck, a rotator cuff tear that's completely referred from the neck, carpal tunnel syndrome that's completely referred from the neck, or thoracic spine. And so we wanted to try to look and see if we could find association or some indicators that it might be of benefit to screen the spine in a much more thorough way.
Yeah. Some of the results were really crazy. I was like, I want to talk about that. That was the amount of patients that were referred with a diagnosis of, like, as you said, a rotator cuff tear, or like any of these pathological models that were quickly reversed. So for me, that number was crazy. I think it was 71 or 70 something percent.
Yeah, very
I wrote it down.
One of the scariest things was there was a much larger error rate in orthopedic referral. I'm kind of jumping ahead, I guess, but while we're on the topic, it was I think a 71, and I'll refer back to it when we get into that. But I believe it was a 71% error rate in someone that was referred from an orthopedic surgeon or orthopedic specialist, in that they would come in with knee arthritis, and it was 71%, and it was spine referral. And I talked on another podcast about that error rate, and I think that this is probably one of the biggest things I think for the study, is that the more grand implications of it is that that person goes to traditional PT with spine referral, does a bunch of quad sets and rides a bike and walks on a treadmill. They don't fix their spine problem. They're referred back to ortho. And if they're a certain age in America, at least, I don't know how it is in Brazil, you've probably seen some discrepancy or difference in how fast things move in America. But in my experience, that person could be lined up for a knee replacement within a week. And I've had plenty of patients that have had a knee replacement, they're no better, and they have a spine referral. And it's, that is wild, because that's a major surgery. It's wildly expensive, and it's a huge issue that isn't addressed in the current orthopedic world, which is why this study and Richard Rosedale's Expo study, and there's a Japanese study about that, I'm forgetting the author's name, are so important, because if you miss that, you're never going to get the person better if you don't find out what the pain generator is.
Yes, absolutely. I just had a patient 3 weeks ago. It was hip pain, couldn't walk more than 8 minutes. And then it was on the first day assessment, sustained extension. He walked this last 3 weeks. He hasn't felt any hip pain. And I was like, the referral, the doctor said, I don't remember the diagnosis, but it was something on the hip. I don't know if it was just hip pain or lateral or something. And I feel it's just how many patients that we missed in the system. And I don't know how we can change this culture, and especially they are the orthopedics, they are the ones that have the final word. So I just think that's insane, like how the system is broken.
It's really wild to see. I mean, it's been, not unfortunately, but it's been kind of, that's very common for me, as it was at the old clinic that I was in with my father. We were kind of the specialists in the area that were known for fixing complex problems. So a lot of people would come to us with failed PT, with failed surgery, with all these things. But in hearing that, it reminds me of probably, that first job that I had where I was doing traditional PT. I remember this really angry Frenchman. I was in New York City on the Upper East Side. People are very demanding. They want everything better yesterday, and they don't care, And this woman had a pubic ramus fracture. And I'm like, I don't know, what am I supposed to do with that? I'm doing all the traditional PT stuff, and she just keeps getting worse and worse and worse. And after I took the MDT A course there, I was like, I guess I'll just look at her spine. And I was not confident at all doing that to an orthopedic diagnosis from a surgeon. And I'm 25, I don't know anything yet, and I'm like, I think I was just honest with her. I was like, hey, I just took this course. Do you want to try something different. You're not getting better. We might as well see. And she comes in the next day and she just walked like 20 blocks and she like hugged me and was like, I can't believe this. I don't have pain anymore. I'm like, are you serious? Like, what, how? And she's like, that weird move you gave me, I'm all better. Like, I'm like, huh. And at that point, and then I started realizing that the orthopedic world often has it wrong. And it was terrifying to see that. And so, that, though all of that, those experiences led to me wanting to be able to explore MDT and facilitate it at the highest level, which is, well, I guess what I'm still striving for. I don't want to say I'm the highest level because I'll get in trouble with the Institute probably, but I've worked pretty hard to be good at it.
And so let's talk about the other results that you had some spinal referral projections.
Maybe I'll just walk through a little bit more of the study and then get into the results if that's okay.
Yes, perfect.
So basically, we looked at 37 consecutive patients that just came through our door, business as usual. We didn't try to elicit patients for the study. We asked them to sign consent to use their information, but didn't use their name or anything like that. So, and didn't alter care in any way. So it wasn't like a randomized control trial or anything like that. We just treated them as we normally would. And so it was patients that came in with a peripheral medical diagnosis from a referring doctor, nurse practitioner, chiropractor, midwife, whatever. Or in my old place of work, Maccio Physical Therapy, we usually would trend around 50% of the business has been there for 35 years and people just know it really well. And we have a lot of people that self-refer themselves because they've either had a positive experience there previously or know of us through friends or family or referred from a similar source like that. So it was people that had a specific medical diagnosis or thought that they had a peripheral problem. So they came in, I have a wrist problem, and it's isolated wrist pain, and didn't have a medical diagnosis. And there's an interesting chart in the study that shows all of the patients' medical diagnosis, MDT classification, and directional preference. And I think it's just helpful to see, like, for especially younger clinicians, like, hip bursitis, that can be a derangement, or, there was second metatarsalgia that with edema that got better with spinal movement. And it's like, really, that can get better that way? To me, even still, that seems foreign. I know it can happen, but I'm like, it's an odd thing to witness. So for new clinicians, I think that's really helpful to connect what they may see on a script and say, well, there's this study that shows that can happen. So we intentionally did that for that purpose. So anyway, I was working with another student of mine that was part of the MDT-specific student program, and she helped a lot of the treatment and structuring of the study and everything, and was really smart into research, so that was helpful.
I really like it, just interrupting you really quick, to see the movements of each derangement, like the shoulders, reflection, internal rotation, external rotation. It was just interesting to see all the different directions and movements that were effective on the derangement. So I think that was really cool and helpful.
And as a young clinician, I used to love reading case reports and case series for that specific reason too, to see what are other people doing. A lot of times this wasn't that large of a study with 37 patients, although it felt that way to me. It's been my largest study. But a lot of times the clinical end of a study like that gets lost. And you could read it and get all these results, but then to go to the clinic on Monday, you might have this idea like there's more spine referral, but how did you get there? So I think that having that, and that's always been a theme of my studies, to being primarily striving to be a very good clinician. I've always tried to heavily embed that within the research component so that you could read it and get it. In the wrist study, we did a specific case. We put all the directional preferences in there, but one specific case study within a case series so that you could read it, which was the most interesting one, and get the clinical reasoning from it, get the differential on it, figure out how the thought process of why we would alter the loading strategies, how much we did, how much force we put through, how much time we spent on each thing, which again, I think for a new MDT clinician, sometimes the semantics of all that, or the how it actually works from day to day, is lost. And I think that's important, because you could test something for 10 reps, didn't work, and then move on, and you missed it because you needed to do it for 48 hours or 72 hours. Or so all of this is meant to kind of help people understand that better.
I think that's super helpful, especially the ones that we work by ourselves. You don't interact with many clinicians, you don't discuss many cases. So I think that was really cool.
Exactly. Well, thank you. I'm glad that you appreciate it. So let's get into the results a little bit. So we looked at 37 consecutive patients, and there's some information just on, we sometimes move people up to 50 times to elicit directional preference. We were using mobilization and overpressure day one if we were suspected derangement, and we're looking for confirmation. One thing that I thought was interesting that we did this in the wrist, we were searching for the most reductive directional preference. So we were attempting to get abolishment of all pain day one if we could. So we ended up moving people more probably than usual because of that, which I think led to a lot of different interesting loading strategies, especially in the wrist study. There was a lot of new, for me, and I think for most people, loading strategies that were elicited at the wrist. In this study, most of them I think were fairly straightforward, at least from my perspective. But anyway, so to elicit directional preference, we cited other research. We wanted at least a 2-point change in pain, at least a 50% change in range of motion or functional baseline. So, pain was the main driver, and we set a much higher change in functional change, and movement change, because I've just seen people get a little bit of movement change out of something and be all excited about it and think they're on it, and then it's incorrect. And then, they might completely miss the classification because that person comes back with better, and like from a general PT standpoint, you can stretch anything a little bit and get moved better. So I wanted that to be significant if there wasn't pain reduction, because not everyone had pain reduction. Sometimes it was just a movement change or a functional change. I think that's also kind of important. And then the variables that we looked at for prediction of peripheral derangement. So these were people that we confirmed had an elbow derangement or a knee derangement, and we wanted to try to figure out what is their directional preference. We monitored mechanical stress, directional vulnerability, painful movement, and obstructive movement. So mechanical stress was something that they did a lot. So, like, for instance, a knee, let's say someone that exercises a lot and bends their knee a lot and sits all day at work and flexes their knee a ton in their life. This study was also echoed in the wrist study, found about 90% of people's inverse relationship to that mechanical stress was the opposite movement. So the person that flexes their knee a lot, they needed to extend their knee a lot. So if you hear that in history and you can confirm that there's knee derangement, you don't have to move someone for 3 hours or for 3 weeks to find directional preference. You might get there very quickly, which was interesting. And not something that in the peripheral joints and spine, we talk about that all the time with posture and provocative movements. But in the periphery, I didn't really think about it that way. I had some kind of previous to this, I had some moves that seemed to work a lot, and I just tried them. But I found myself testing people more and moving people more. It was more frustrating for me, more frustrating for the patient, because most people don't want to be moved around more than they need to, especially if it's uncomfortable. And then the variables that we looked at for spinal prediction were detectable peripheral movement loss, detectable spinal movement loss, paresthesia, and these next ones are a little confusing, I think, but are relevant because they ended up being associated with spinal referral. So we looked at pain at rest, constant pain, intermittent pain at rest, and intermittent pain or intermittent symptoms without pain at rest. So, for instance, that last one would be like if you just move your shoulder and there's a painful arc at 90 degrees and then there's no other pain, it never lasts, it never lingers. It's just, so I didn't used to think about that either, but there was some connection as we get into the results of that. So in evaluating all of these patients and tracking all that data with them, we inputted it into an Excel sheet and did secondary analysis on it and ran statistical measures on it to find association. And so 37 patients, the original provisional classification, there were 12 extremity derangements, no articular dysfunctions, no contractile dysfunctions, 14 spinal derangements. And then there, in the other section, there was 2 traumas, 1 post-surgical patient, and 8 inconclusive, so a total of 11 in other. After testing, either day 1 or a lot of these people ended up changing over the course of 24 to 72 hours, probably a couple, maybe within a week, had a change in classification. And so the extremity derangement went from 12 to 16. Articular derangement went from 0 to 1. We had no contractile dysfunctions. Spinal derangement went from 14 of provisional classification to 17. And then the two traumas stayed the same, the post-surgical stayed the same, and the 8 inconclusives all changed into either extremity derangement or spinal derangement. And there was 1 left as inconclusive. So the total numbers or the total percentages on that were, I'm gonna have to refer back to that, but basically 89% of all of them were either a spinal or peripheral derangement, which is a ton. Everybody's a derangement basically in this sample, and then it was 45% spinal, and then 43% peripheral. So both pretty high. And let's see, yes, 87% actually did have a pathoanatomical diagnosis from a medical specialist, and which 45% of those were spine referral. And that kind of echoes that 71% error rate within the orthopedic referral. And interestingly, only a 16% error rate in the primary referral, which I don't find typically that primaries find spine problems more. I don't know why that was, but I would think they would be kind of equal, because I don't necessarily think most primaries that I work with at least are better at detecting if there's a spinal problem, but within these numbers, that was it. So then if we look at those numbers, in the main probably point of this study, some of the bigger numbers to predict spine referral, or bigger components to predict spine referral, were if there was no detectable movement loss. So if you range a shoulder and it's exactly the same as the other side, there's no obstruction of movement, it was a 73% chance that was spine referral. So that's really interesting to me. It was just referenced in a case series. I believe the author's name is Joseph Hathcock, where he found the same thing in a study that he published with a patient, that there's no movement loss, and he referenced the study, which I thought was really cool and exciting to see. And I see that often. Some exceptions at the knee. I've seen a lot of patellofemoral derangements where it appears there's no movement loss. And at the elbow, I've seen a few. And actually in our elbow study, the first study that I ever published, we get into kind of the pathoanatomical model of how that can happen. And there's multiple studies that reference joint displacement, the different pieces of articular tissue that can get entrapped within the joint space. Mercer and Bogduk talk about that. DePark is another study that talks about that. And even back to the 1930s with Dr. I think it's Percival Mills. He was the first one to kind of treat successfully tennis elbow through the Mills manipulation and had a lot of success with it. And he had dissected some of these elbows, I guess, and found that there was a ligament that would get displaced under the extensor tendon. And there was a patient within that case series that he originally had movement loss and didn't, and we ended up using a similar technique to the Mills manipulation, which tautened the extensor tendon so that it compressed the exterior of the joint space. And it was just a really interesting connection from what potentially is happening anatomically and how we're addressing that clinically, and how that kind of challenges that within the MDT system. I think it's still that you should have movement loss in the peripheral joint to confirm a rule in a joint derangement. But there's some exceptions, at least from what I've seen and published now. So, but it's more common that if there's no movement loss of the joint, I think it is smart to test the spine for 24 to 48 hours, even if you don't think it is or the person doesn't think it is.
Yeah. Just commenting about what you said before about the number of patients that had the pathoanatomical diagnosis, and that 45, almost 46% had isolated extremity pain generation exclusively from the spine. So just how big is the error on like referring to a specific part and then that specific part not fitting on that model being actually like a derangement, for example, of the extremity, and a lot of those coming from the spine. So like I think it's a lot of chances that you have to miss the diagnosis for the patient. So you have to first go and assess, and then a lot of them coming from the spine. So I just think it's crazy like that this model, like the patient that's coming for us, like has a lot of chances of not getting that right, because looking at these big numbers that you just found. So I think that's insane.
Wild. And and that's not just something that I'm finding. That's now there's been multiple studies that are finding around a similar rate in the 40s, in Expo study in the 40s, in the NEOA study, that it's spine referral. And I didn't track it in this way, and I haven't tracked it formally, but I see typically a descending prevalence as you move more distally in the periphery. So I see a lot of hips that are spine. I see a lot of shoulders that are spine. I don't see that many wrists or ankles or toes that are spine, but I see it. And as we get into some of these other variables that are predictive of spine referral, I think that can make it more easy for people to detect. But in some of these people, the medical diagnosis, you evaluate the patient and you're like, you have a full-on cervical radiculopathy and you're being told you have a shoulder impingement. Like it's a complete joke. And it's just because they go, I got shoulder pain, they get x-rayed or MRI'd and have a special test that's positive, and that they never even ask if they have numbness. So the next variable on there is reported paresthesia. And that was identified in just over 40% of these people, or this patient sample, and which isn't a ton, but there was 0 in the peripheral derangements. So that 40% was highly specific in ruling in that spine was present. So anyone that had paresthesia, it was spine. And that's more, I think that's something that you would probably learn in PT school. That's not mind blowing. But I think relevant because there are a lot of people that are told to have peripheral nerve entrapments. And I just don't see that a lot. I don't see that the peripheral structures cause paresthesia often. Detectable spinal movement loss was reported in just over 50% of people, or identified in over 50% of people. So if someone had loss of movement with right rotation and a shoulder problem, it makes it a lot more likely that there's spine referral or a loss of extension or whatever it may be, which also I think makes sense. Pain at rest and constant pain, I think, are two interesting variables. Most spine problems had pain at rest. So you do something, it hurts, it may stay painful for 10 minutes, it may stay painful for 3 hours, it may stay painful for 5 hours. Very few, or much less patients had intermittent pain with no pain at rest in the spine. It was maybe 3 or 4%. So most spine problems either had lingering pain that sticks around for a while and or constant pain. And the constant pain is probably a better differential for people because it was under 10% of peripheral derangements that had constant pain. So it was very unlikely to see a knee derangement that reported, I have unrelenting pain all day. You move it around, there's usually a position or something that helps it or hurts it. So if you hear that also on a history, or if I hear that on a history, I'm screening spine heavily. And in the spine, it was at 55%. So 55% of spine patients had constant pain, and in the peripheral joints, it was under 10%. So that was a big discrepancy that, when you start to layer these and you get a person without any movement loss, constant pain, that has spinal movement loss, we didn't quantify it this way, but it starts to build an even stronger case that this is highly likely spine referral. And even if I'm wrong, we need to test it, because if we're wrong, we're going to be doing God knows what for a long time if the pain generator is coming through next. So I'll often cite those things, not necessarily referring to myself, but to people, just so that it takes kind of opinion out of it. And it's like, I don't necessarily want it. So someone that comes in with elbow pain and they start moving their neck around, you can sometimes get disagreement with. So I think that's helpful to refer back to the research, because it makes it more objective, and it's like, this is following scientific method, and this is what we need to do to help see if we can help you.
Yes.
I found that tactic to be very helpful, because this concept's confusing people. They went to an ortho, they get an MRI, they come in.
Yeah.
Half of the battle is figuring out what that person's educational level is, what their motivation is, and how you can connect and educate them on what you're about to do and where this might be coming from. And again, partially this research is to help with that, I think.
Yeah. I've done that sometimes, especially like referring to the Expo study. So it's like, well, the number of hip that comes from the spine is really big, as this study showed, and then I show them. I think that really helps to get their buy-in, so they are more open to like try and understand the process, versus we're just trying to explain and we're like, well, but my pain is not there. So I think that really helps us as clinicians, using that as a tool to help explain that to our patients.
Absolutely. So next time we talk, I'll be expecting you to be referencing Maccio et al. With your spine.
Absolutely.
You were published. I listened to Richard Rosedale's study, and I think he implied that he was the first study to predict variables of spine. But we were published in 2018, well before the Expo study. So
no feelings hurt.
No, it's a very similar study, and it found very similar things. It was a much larger sample, but they complement each other much better. And I think that there's very good numbers in that. I think that connected to this study, you get a little bit more of, as you said, some raw clinical pearls that can help you in finding directional stuff like that. So the constant pain, highly predictive, and peripheral problems were just much more intermittent and very unlikely to have pain at rest and or constant pain. So I think those are kind of the highlights on spine. One other interesting thing that was in here was that in the upper extremities, there were, let's see, of all of the upper extremity spine referral, 71% required some form of thoracic movement. And that wasn't something that I was doing a lot. I used thoracic movements a lot for cervical problems or for problems in lower cervical spine or the cervical thoracic junction, or to get a cervical movement to be facilitated better. But I wasn't necessarily testing thoracic movements for peripheral referral. And you found with this either a straight on thoracic movement or thoracic mobilization, or combined. I often use a combined movement with cervical retraction extension with thoracic extension. That something with some form of thoracic was required to elicit directional preference of spine referral. And I thought that was really interesting, because if all you did was screen the cervical spine, you'd miss 30%, you'd miss potentially 70% of these people with peripheral spine referral. So I thought that was
a good reminder. Yeah.
And this again was something that I've always used a lot of thoracic movement because I learned that from my father early on. But for some reason, I never considered it to do it in peripheral joints until I got older. Now I'm a lot older, wiser, I suppose. But yeah, so that was really interesting. And then if we look at the variables that were associated with directional preference of the peripheral derangements, and I don't think anyone actually. I don't know. The Expo study is also out there, and there's other spine publications, but I don't think anyone else has actually tried to predict or find association of directional preference in the periphery. So this is a unique thing to this study and to the wrist study that anecdotally I see being very helpful. So the mechanical stress was the highest associated at 90%. So in the wrist study, that there was a high prevalence of people that were doing a lot of wrist extension, and a large amount of those people came from a gym that did like a lot of exercises that hyperextended their wrist and like just hundreds and hundreds of reps, and they all needed flexion. And this study was all over the map, but another common theme, and I think a little easier to visualize, is the knee problem. So, for instance, people that bend their knee a lot, most people sit all day, like you and I are right now. As physical therapists, we're kind of up and down, so it's harder to predict what excessive mechanical stress may be in someone like us. But in a lot of people, they do the same thing over and over and over all day. And if you connect that with insidious onset, which is most people, it's like, well, why would that happen? And if you start to ask and pluck out what their body is doing all day, you, at least in this study, you have a 90% chance of using the inverse movement to get there. So you can do that very quickly. Day one, you look great, and this is easy. You got to move them 30 different ways. The compliance starts to get negative. You start to lose your confidence. You might lose the patient. They might go get acupuncture or surgery or whatever it is. So, the faster I think that you can find this, the better. Same thing with directional vulnerability. That was a little lower at just under 80%. And basically the same thing. It's just that's something that they report doing. And I thought a really interesting variable that didn't connect as much as I thought it would was the patient's most obstructed movement. And in some joints I see that often is the case. In the knee, I see that a lot. The most obstructed movement is knee extension, and that ends up being the movement that is better. In the ankle, I see that. In the more complex joints, I don't see that. A lot of times, like in shoulders, flexion might be the most, or abduction might be the most obstructed movement, but doesn't end up being directional preference. And in the wrists, it was around also. This was just over 50%. I think in the wrist study, it was at around 45%. And just from an intuitive, I went to physical therapy school standpoint, that's what people do. If something's tight, they stretch it. And in a lot of people, that isn't the case. So I think that's just interesting. Maybe it's less predictive of what to do, but just something to know that if pursuing only that is likely not to give you the answer. And then connecting the patient's most painful movement, which also as a young clinician, I didn't like to do. It was like, it just felt wrong, or I felt uncomfortable, or I didn't want to have to pursue that with a patient because I knew it would be uncomfortable, and I just wasn't confident enough to know that that was going to be something that was helpful for them. So in the wrist study, it was around also, I think, just under 50% of patients with most painful movement that helped them. In this study, it was a lot less. It was, 33. Thank you. And look at that. You know my study better than I do. 2018 was a long time ago for me. Lots happened since then. But I'll reference that a ton too, because I can't tell you how many patients I will be confident this is what you need to do. Let's go ahead and do it. And they give me a lot of kickback if it hurts. And in referencing that, it said, look, there's research out there that says half of the people need to do the most painful thing, or they're not going to get better. If not doing the most painful thing was going to make you better, you would have done it on your own, So that also, I think, gives people confidence that it's not just me doing that for some reason.
Yeah.
But that's what the data shows. That's what the research shows. That's out there and that happens. And that also makes people more confident in doing what is going to be helpful.
I think it's just all like good starting points. So you know what to start trying, that you have the higher chances of getting right.
Yeah.
So you don't lose the patient. And for me, it was very interesting to see the as you said, the mechanical stress. So that's sometimes something that I wasn't paying that much attention, like to extremities. The back, I think it's very obviously for us to think this way. But like as you said, extremity, I wouldn't think about the knee. Well, you were sitting whole day, flexion, so probably extension. Let's try extension first. Sometimes you just pick one way because you don't really associate with anything. So I think it was really good to have that as a baseline, a starting point, and then you go from there. So you don't have to test everything. You just kind of have an idea of what to try first. So I think that's really helpful.
Yeah, I agree. Again, previously, I didn't. Previous to those two studies, I didn't really think about that either, and I had a bunch of movements that seemed to work often, and I just kind of resort to them.
Mm-hmm.
They were what I was familiar with, and our numbers, I think, in prevalence of derangement in the peripheral joint and the spine, I think are so high because we're figuring it out easier. And it's not just, I made a joke, and were you at the Miami conference?
No, I was not.
I presented the risk study at the Miami conference, and I made a joke about, and I referenced it in the study, but we follow the research of that. If you were following the research at that time, there were only two published directional preference procedures, which was wrist extension and ulnar deviation. And if we only used those two movements within our wrist sample, we would have only had a 20% prevalence rate of derangement. So if you follow the research, you'd be nowhere because barely anyone needed those two movements. And I thought that was really interesting too, because it's so new. I see or think that people just don't know what to do or didn't. So I think that was reflective in previous research, because there's been an ascending prevalence in those two syndromes percentages through the years, starting at 20%, 40%, and ours at 79 was the highest of the risk. This was lower. If you combine spinal and peripheral, it was really high, 89%, but 45. And if you excluded spine, it would be probably 90%, because there was only a couple others in the mix. So, yeah, but anyway, I made this joke saying that my father would fire me if I was only getting 20% of my patients better. It went over really well, but I'm not as funny as I used to be, so. But yeah, I think those are kind of my key takeaways from this and the highlights of it. There's tons of spine referral. There's a few variables that are highly predictive or associated with spine referral: constant pain, no peripheral movement loss, paresthesia, and if you have a peripheral derangement, mechanical stress can be very helpful with using the inverse relationship of it, and start thinking about those other factors. And then, I think just using this, because as you said, if you're a clinician that works by yourself and you get a large orthopedic referral, it's intimidating to say that they're wrong, but it's our job to. So we're working under my father in that clinic. We kind of had a situation where that was our reputation for doing that. So there was a bit more of expectation of us to do that. So it made it a little easier, but it was still really uncomfortable for me to have to educate and almost be argumentative at times with people, so being able to reference research made it, when I started doing that with people, even printing the study out and showing them, or, I use a lot of different research to educate people. And when I do that, it makes it more objective. It takes my opinion out of the matter. And I agree with the surgeon or you, but we need to do this. And if it gets better, then that is what it is, but it happens. I think just coming at it from that angle makes you sound smarter, more thorough, more caring, and makes you less likely to get disagreement. So I think that's a helpful thing to hear to clinicians.
Yeah, absolutely. And especially like the patients that have this medical diagnosis so strong in their minds. And so my MRI said that, my doctor said that. So I think it's really hard. So that's a good thing that we have in our favor to use. So to reference this study. So I really appreciate you doing that for us, for our profession, because that is really helpful, because I think it's really hard to argue per se with these patients or try to convince them or explain them. So I just think that's so important. So
I've put our family name on the line for everyone. So now if anyone's mad, it's because Maccio et al. Said so, I guess. So I was getting myself into. I hope my father doesn't get any kickback from this, or I'll be in trouble.
And let's then transition to our final questions.
Oh yeah, that's right.
So what is your favorite resource of information? Anything in particular that you like?
I think that the McKenzie Institute does a good job of keeping up with the current reference list in terms of if you go to their website for McKenzie International, and I think it's under resources, they keep a fairly current list of new research that comes out that either is specifically related to MDT or has a high connection to it. So I think that's an easy starting point for people that are busy, that don't want to go through every journal. When I was very much into publishing research, I've had a bit of a lapse since the last study that I published, but I would go through maybe monthly all the different journals that I liked, JMT, Spine, JOSPT, and then a bunch of other ones, manual therapy, and I would just look to see what was new there. So I think those are two helpful tools. There's a lot of stuff, I guess, on social media and stuff that's always out. I'm not that huge into all that. Being so old, that just doesn't connect to me. But
it's just a lot of work and time. Social
yeah, yeah, and there's a lot of misinformation and things like that out there. But we used to, when we published all these, I have in my profession taken a lot of time to read a lot of research and to try to stay as current as I can. But most people don't. I can't tell you how many people I've met at a conference that are like, "Oh, I heard you had a new study." And I was like, "Yeah, did you read it?" And they're like, "No, I was gonna, but I just never got around to it." And I'm like, people just are busy. That's life. So because of that, with a lot of the beginning studies, we wanted to gain as much exposure to it. There's thousands and thousands and thousands of studies that are published every year. So we did kind of like promotional, summative, and like fun videos on YouTube of them, which gave you a snapshot of what it was, showed you some loading strategies. And I mean, our most popular ones probably have been viewed by like, I don't know, 20,000 people or something, mostly MDT people. And I don't know for a fact, but I would be shocked if 20,000 people read this study. So, there is some value, I think, in that, and that's a quicker, easier way to kind of see. And it was just a way for us to try to get the information out there to the busier,
just make it easier.
busier
Yes.
PT clinician.
Yeah, good. And then what would be the best advice you give to a clinician that's starting their careers?
Yeah, there's probably so many things. I think that developing the desire to learn more and challenge more. Within every patient that we've talked about, it's been a challenge to say you don't have knee OA, you have spine referral, and if I looked at myself when I graduated PT school, my prevalence rates of derangement syndrome would be nil, or one. That one French woman that I accidentally got better. I didn't get a lot of people better, and I think it's a difficult thing for new clinicians to say what I learned in PT school is wrong, and to test things this way. I think it's difficult for an old clinician to say for the last 10 years, my patients haven't been getting better because I had the wrong, pain generator, or I didn't have the wrong classification, or I didn't even know what the classification was. So I think that just trying to be confident and humbled in knowing that you might be wrong, and not being scared to test things to learn more. That's led to a lot of my success, and it was hard initially because testing someone can be uncomfortable, especially if you're not confident in it. But it's led to way, exponentially more people that I've seen get better. So that's kind of an indirect answers, but I think that taking continuing education, trying to get good mentorship, so that you can learn that. And that's a large reason for my success in all of this. Is fortunately, I had a father that was a diplomat. So if you have a father that's a diplomat, do that. If you don't, try to seek other forms of mentorship, because you can really expedite you take a course, you learn something on the weekend, and then you go home, and it's not always applicable. It's like, well, what happens day 2? What happens week 2? What am I supposed to do now? I always found that kind of lacked if you didn't go through the full diploma program unless you work with a mentor. So just the willingness to be humble that you may be wrong, wanting to challenge things and test them in a more scientific way, and getting mentorship, whether it's an MDT, whatever you may be exploring, I think is probably one of the smartest ways to be successful.
Absolutely. And then final question, what personal qualities and abilities that you think are important to become a successful PT?
Geez, that's probably my last answer. I should have held that. Yeah, I think, to be a successful PT, I'm not so sure about to be a successful MDT clinician. I think you need to be willing to challenge and confidently challenge and scientifically challenge a lot, because everything that we just said, 89% of what I saw was wrong. So that's crazy. And I think another thing that has helped me greatly is, a lot of my job or our jobs is really easy when you get good at it. I could read an eval sheet and say, this person needs to go do this, and that's it. 2 minutes, it's done. I can leave and have it figured out. But the hard part is convincing a patient of that. So I think that trying to connect to a patient in a way that you understand what their educational level is. I have certain patients that don't need to know anything. Maybe I know them from before. They don't care. They trust me, and I just can do that. Okay, this is what you are. This is what you got to do. You'll be better in a week. I'll see you in a couple of days to make sure of it. See you later, and that's easy. There's other people that I need to print out this study. I need to go through the statistics. I need to give them a book. I need to do a diagram. They got to talk to my father. They got to, everything under the sun, I need to re-educate them on to build confidence. And for a lot of those people, I'll give them the treat your own books to read. Because, especially where I was before, I was very busy and didn't often have time to field all those questions and the amount of time that I had with that person. And that often, especially in spine problems, was very helpful, because they would then have a better education of what we did and why we were doing it, and answer all of their questions. And usually they would come back without a lot of questions. So I think that's a helpful tool. In spine referral to the periphery, it's not as lay language that talks about that. So to give someone this study to read, it might be a bit over their head or whatever, or I don't know. But I think that it's not. This isn't something I hear people talk about a lot. But being a good listener and trying to understand where someone's coming from, and then how to connect the educational component of what you're doing to what they know. Because if you can get that agreement early on, especially in something less known like this study, you're much more likely to have success. So, just thinking about that and trying to connect that is I think a very important quality that has led to a lot of my success.
Yeah. It's not enough to just be a good clinician. You have to have a way to transmit that, engage with the patient, and get their buy-in to do what you want them to do and be willing to try. So that's a big part of the success.
Absolutely.
So Joe, thank you so much for taking the time to share with us your study. It was very insightful. It was really good. It gave me a lot of insights, and I'm sure for a lot of other PTs that are going to listen to us, and for some reason, maybe they haven't read the study, so now they have like a full discussion with the author. So I think that's really helpful, and our goal here is just to share information and help as many people as you can. So I appreciate that you've been doing that, your effort, your research to help us grow and help us improve as therapists. So thank you so much.
It was my pleasure, yeah. And thank you for doing what you do and spreading the word and helping educate people. It's a great service that you're providing. So